بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. We'll start today our revision. We'll start by anatomy book 1. It will be amazing revision with Dr. Suzan inshallah. And with me all updates I will try to share it inshallah. اهو مقدم اهو. اوكي وحسبي الله ونعم الوكيل. We can start.
Dr. Brawa, Aziz.
Yes, Aditi.
Hello, can you
Yes.
hear me?
Mhm.
Hello?
Yes, I can see the screen.
I can't hear you well.
Your voice not clear, bro.
Hello?
Yes, Susanna, I can see that. Yes, I can hear you if you can
now,
hear me well.
now your voice is clear, yeah. Okay,
Okay.
so let us start our first station of the first picture. And could you identify the structures, please?
I29. Okay, the A is, this seems to be lingual nerve. The B is anterior belly of digastric. The C, superior belly of omohyoid. The D is sternohyoid muscle. The E is sternocleidomastoid. F is clavicle. G is subclavius muscle, I think. H is posterior belly of digastric or stylohyoid. The I is trapezius. The J, I don't know what the J is. Accessory nerve. I think it's indicating to the nerve, accessory nerve. And the K, I can pass the K. The L, same for L, I can pass it. M, I don't know what is the M, but N is also a brachial plexus.
So the A is the marginal mandibular, not the lingual. The G are the fibers of the pectoralis major. The H is the posterior belly of digastric, as you mentioned. I, this splenius capitis. K, the scalenus medius. L are the fibers of the trapezius. M, the omohyoid, inferior belly of the omohyoid.
Okay.
What is the structure with the yellow arrow?
The structure with the yellow arrow is posterior auricular nerve. Oh, great auricular nerve. Sorry.
What are its
The root
values?
value. Yes, the red value. The root value is C2 and C3. Nerve cervical 2 and cervical 3, and the sensory distribution is to the angle of the mandible, the lower half of auricle, and the skin overlying the parotid gland.
Brilliant. So could you identify the structure number 16?
Can you please point it to me? 16, I cannot see, I cannot find it. 16, let me.
Here?
The 16 is great auricular nerve, seems to be.
Yes, brilliant. Would you identify the spinal accessory nerve, please?
Spinal accessory nerve is supplying the sternocleidomastoid and trapezius, so the nerve from the, it's 26.
Here up, while it's
Or
passing out of
yes,
this
one.
skull, going to the sternocleidomastoid, passing posteriorly to the posterior triangle to give the trapezius. So it's number 1.
One. So one.
Could you identify
Yes,
the
one.
muscle supplied by it, please?
Yes, sternocleidomastoid and trapezius muscle are supplied by spinal accessory nerve.
What are the numbers for them? Identify them, please.
The number of them, yes, sorry. 43 for sternocleidomastoid and 61 for trapezius.
And how to test their function, please?
Regarding the sternocleidomastoid, I would ask the patient to strike his shoulder. As for sternocleidomastoid, I will ask the patient to lateral flexion of the head.
And both should be against resistance, definitely. If
Yeah,
it's
sorry,
injured in the
sorry.
posterior triangle, the spinal accessory nerve. If it's injured in the posterior triangle, which muscle will be affected? Which of them?
If it's in posterior triangle, common sense, trapezius should be. I'm not sure 100%, but I
Yes,
think
because it
trapezius.
supplies the sternocleidomastoid before it passes to the posterior triangle. Would you identify the omohyoid muscle, please?
Yes, the omohyoid is, we have two bellies of omohyoid, superior and inferior one. Regarding the superior is 54 and 21. Am I right?
Yes, this is the superior, this is the inferior belly. And what is its nerve supply, please?
Omohyoid, the nerve supply of omohyoid is from ansa cervicalis, which the nerve group is C1, C2, and C3.
Good.
Part of strap muscle.
Before going further, in your key last exam, ask it what is the origin of hyoid.
The origin of the omohyoid, okay, from the hyoid muscle, from the hyoid bone. I don't know the extension of the hyoid muscle, to be honest, but I know one of the incision is the hyoid bone, and then it goes to the posterior triangle to divide the posterior triangle to the.
Or he's asking origin and the insertion.
I think clavicle and the hyoid bone. I don't know, to be honest.
From where of the clavicle?
Middle third, common sense. I don't know.
Okay. He's asking the question from where to which part of the scapula. Yeah, I'm more clear with you. This in UK last time. This update. طب كويس still I have updates. So why why I'm sad؟ دي جديدة يا سوزان صح؟
Yes.
طيب يلا. Which part of the scapula? Upper border of the scapula.
Above the scapula. Okay.
The top of the scapula. Okay. Excellent. So origin and the insertion of hyoid. This is new question. Attachment of hyoid muscle. Suzanne, I will try to search and they will send a good picture for them. Okay.
Okay.
يلا continue.
Okay, from this picture, please, would you identify the submandibular gland?
Okay, submandibular gland is 33.
Yes, definitely. And what would you name three nerves that are at risk on excision of the gland?
Okay, submandibular glands, when doing the excision of submandibular gland, three nerves are at risk. First of all, is hypoglossal nerve. Secondly, is a lingual nerve, part of a mandibular branch of trigeminal nerve. The other one is marginal mandibular nerve, branch of facial nerve.
And would you mention function of one of them, please?
The hypoglossal nerve supplies the all muscles, intrinsic and extrinsic, apart from a palatoglossal nerve, the motor supply of the tongue, while lingual nerve, which branch of mandibular nerve, it supplies the anterior two-third general sensation of the tongue, while marginal mandibular nerve supplies it's a part of a facial motor. It can be tested by just asking the patient to show his or her teeth.
So, what is the muscle lying between the gland and the skin?
A platysma muscle.
And what nerve or which nerve supplies it?
A branch of facial nerve called a cervical branch.
How to
And
test its function?
regarding the tensioning of the neck, we can ask the patient to tense his or her neck.
I just have one comment regarding the
Sorry, Suzanne.
question.
Suzanne. Sorry.
Yeah?
Again, sorry. You can answer question number 11 again.
Number hypoglossal nerve, marginal mandibular nerve, and lingual branch of mandibular nerve, branch of the trigeminal nerve.
So what will happen in injuries of this nerves?
Hypoglossal nerve is a motor supply of the muscle of the tongue, intrinsic and extrinsic. if there is a paralysis of a hypoglossal nerve, it's going to lead to muscle atrophy, deviation of the muscle to the affected side, and fasciculation of the tongue. Regarding the lingual nerve, if it's injury, the anterior two-thirds of the tongue, sensory, by sensory I mean general sensory, it will be affected. And marginal,
what about taste will be affected or not?
it will not be affected because it's chorda tympani branch of the facial nerve will supply the taste sensation of anterior two-thirds of the tongue.
Okay.
Regarding the marginal mandibular nerve, it supplies the facial muscles. It can be tested by just asking the patient to show
I'm
his
asking
or
how
her
to test it. What is the function will be lost?
drilling. They're gonna be drilling
Okay.
of the saliva.
I will tell you the answer. This question not accepted in many centers, by the way. This is the ideal answer they are waiting in Cairo, Suzan. In Cairo exam, I remember when asked this question. This station is repeated in many centers, by the way. So from the checklist. From the checklist. يلا اكتبوا يا شباب عشان خاطر اللي هيدي كورس
Okay.
ويعمل كتاب.
Okay.
From the checklist. I shared it written already. Marginal mandibular, it will cause dribbling of saliva from corner of the affected side. Poor speech articulation, slurred speech. Number three, asymmetry on smiling or crying. Three effects. Hypoglossal nerve affection, paralysis and atrophy in ipsilateral side, deviation to the ipsilateral side on protrusion of the mouth, on protrusion of the tongue, sorry, and the poor also speech articulation can be happen here also with hypoglossal. Lingual nerve, loss of general sensation from anterior to third of the tongue and the floor of mouth, and loss of taste sensation from tongue only. Listen, from tongue only. So sensation, general sensation with lingual will be anterior to third and the floor of the mouth. While taste will be affected with lingual from the tongue only. I shared it and I shared with you also taste pathway in the updated notes in mock notes. Anyone not in the book notes, don't send for me. Don't tell in the group, I am not in the book notes. Shinoda wrote for you. Anyone booked the exam, send your booking for Shinoda, he will add you. Otherwise, if you write in the group, write for me, I will not do anything. I will not repeat. It's already in the group. I shared it in the group. يلا. It's in the group already. يلا. Sorry يا هبه يعني عشان نخلص يلا.
Okay, what is the muscle that divide the gland into superficial and deep parts?
Mylohyoid muscle.
And what is its nerve supply?
The nerve supply for mylohyoid is a mandibular branch of the trigeminal nerve.
And what
And
is
the
its action?
yes, the action of is elevating the hyoid bone and depressing the mandible, and it will help in initiating the swallowing.
Yes, the nerve name is nerve to mylohyoid branch of the trigeminal nerve. What is the type of secretion from the submandibular gland?
It's mucus and serous.
Yes,
Type
mixed
of
secretion.
secretion.
Would you identify structure number 9?
Number
Here.
9, let me find. It's an external carotid artery.
And what is the nerve passes just lateral to it?
Just lateral to it is vagus nerve. Posterior to it is vagus. Lateral to it is. Can I pass it? I don't know the answer.
It's the hypoglossal nerve. And what is its
Hypoglossal nerve.
function? You answer this question, please.
Yes.
What are the boundaries of digastric triangle?
The digastric triangle is one of the triangle of anterior neck triangle. The anterior belly of digastric and posterior belly of digastric, and the lower border of mandible is the border of triangle.
And what about the floor and roof?
Can I pass it? I don't know the answer.
The floor formed by the mylohyoid hypoglossus and the middle pharyngeal constrictor muscles, and the roof is by the skin superficial fascia, platysma, and leaf fascia. And what is the nerve supply of the digastric muscles?
The digastric muscle has anterior belly and posterior belly. The anterior belly gets nerve supply from mandibular branch of trigeminal nerve, while the posterior belly will get the nerve supply from the facial nerve.
Yes, it follows its anatomical origin. Okay, given this pathological picture, histopathological picture or histology picture, a patient has a large lymph node biopsy taken. Would you explain the finding of the tissue examination along with the possible diagnosis, please?
Okay. Um, as far as enlarged lymph nodes, there is, but I can see. I don't know the answer exactly. For the sake of the recording, I don't want to miss the explanation. But I think there is hyperchromatosis, maybe lymphoma, or, upon a common sense. And I will leave the detailed answer for Your Majesty, Dr. Susanna.
Actually, as it is lymph node, it could be any cancer because most of the cancers drain to the proximal lymph nodes. So
Okay.
yeah, and there is nothing in the details given that it could be lymphoma because they didn't give you that there is multiple aligned lymph nodes or generalized lymphadenopathy or so. So what you can mention whatever you know about the malignancy features in the histology, like hyperchromatosis, whatever, but the examiner is waiting to see that you have melanocytes here in the picture, and that indicate the most probable diagnosis here is melanoma. That's what the examiner is waiting to listen to. If they ask about the other differential or the second differential diagnosis, you can mention squamous cell carcinoma because the melanocytes could be look like the keratinocytes,
in
so
the
it could be
checklist, Suzanne,
different differential.
in the checklist, it's written for him. Don't give mark for candidates except with malignant melanoma only.
Yeah, if they ask about the diagnosis, it's melanoma, but we don't have any guarantee. They might ask about differential, so we are preparing you for the worst, and it will happen because you are so lucky people.
I agree for your way in discussion. You should extend your knowledge. يعني don't stuck to the mocks. يعني don't stuck for people. يعني this is my advice يا شباب. This is my advice for all of you. The problem for many of you, especially in knowledge part, is that you are stuck in the knowledge. So if we'll ask you any question out of this, you will start to stop. And this is what I discovered with many candidates not to clear the exam because of knowledge. I think the way of discussion with mentors like Suzanne, Murad, and Maria is the best way. Listen for them. If they will extend and going out of our book or going out of mock, this is the best way nowadays. Trust me, you need this. ماشي يلا سؤال.
All right. Would you tell me which muscles elevate the posterior tongue, please? Or the retract posteriorly?
Okay, a palatoglossal muscle and stylohyoid muscle also retract the muscle, retract the tongue, posterior tongue. And palatoglossal muscle, it will elevate the posterior part of the tongue.
They are hypoglossus and styloglossus. They
Yes.
are the two muscles that retract the muscle posteriorly and elevate it. If hypoglossal nerve is affected, what will happen clinically? We discussed this already. We have done with this station. Well done, Dr.
Thank you for your kindness.
Noah.
Yes.
My
From
dear,
Iraq.
my dear, how are you? وراح فين؟ مروان, you are doing great, by
Yeah.
the way. You are doing
Thank
great.
you very much.
So
Thank
please,
you very much.
in private, don't send to me how to study, how to know. You know how to pass the exam. No,
Okay,
because
thank
you
you very much.
send me many message. You know how to pass the exam. Do like this in exam, and you will score very high score.
Thank you very much for
ولا رايك
kindness
يا
and
سوزان؟
cooperation. Thank you very much.
Okay. ولا رايك يا سوزان؟ I
Yeah,
think
really great, yeah.
your evaluation very important. سوزان بالله عليك بدون تقييم يا سوزان. يعني
No,
انا عايز بقى يا سوزان بصي، انا عايز بقى سيبك من اللي اتسرب. عايز يشوف اللايف بتاع شكله، سيبك من الورق اللي في الكتاب، طلعي بقى كل اللي جواكي وامكانياتك، اظهريها بقى. يلا. give them evaluation, give them evaluation also. Yeah.
Yeah, he did really great. What I like that he didn't waste his time while he was answering whatever he doesn't know. He kept it to the end. But I answered them already because of the for the sake of the time and the fluency of the flow of the mock. But in the exam, yeah, it is a very very good strategy not to waste your time trying to recall the answers. Just pass the question, go to the next, and whenever you finish you can go back, because you don't know how much questions is in your station, so you don't know how much value for the question you missed. So it might be just something minor that you could miss easily, rather than wasting the time trying to recall the answer and losing like 10 extra questions next for it. Dr. Abdullah.
Hello. Assalamu alaikum.
عليكم السلام ورحمة
عليكم
الله.
السلام.
Okay, so this is one of the easy stations, straightforward, which doesn't come commonly, but we have to go through it because there is no guarantee what will happen in the future. So, would you tell me what are the typical cervical vertebrae, please?
Yes, C7 and C2, the axis, and C1, the atlas.
And what are their atypical features, please?
So C7, it has a long spinous process and it has small transverse foramen. For C2, it has odontoid process and it has a bifid spinous process. For C1, it has no body and no spinous process.
And what is the most prominent vertebrae in the subject?
C7.
Why it is the most prominent one?
Due to its long spinous process.
Considering the picture of the X-ray in front of you, do I identify the hyoid bone?
Number 4.
Brilliant. In this X-ray, would you identify structure number 7, 6, and 1, please?
Number 1, it is the anterior arch of the atlas. Number 7, it is the superior articular process of the atlas, and the other one was number 6 is the inferior articular process of the no, number 7 is superior articular process of axis. Number 6 is inferior articular process of atlas.
Yes. So number 1 is the arch of the atlas.
Arch of the atlas,
the
yes.
superior, sorry, is the inferior of the atlas,
Yeah.
and here the superior of the
axis.
Yes. All right. Other than fracture line, what else in the X-ray can raise suspicions of fracture?
What can raise suspicion of the fraction is there will be the distance between the odontoid process and the lateral mass will be asymmetrical on each side, and also there will be prevertebral edema.
Yes, so there will be abnormality in the alignment, as you explained, the distance between the adentoid and the lateral masses of the atlas and the soft tissue edema. Brilliant. What are the ligaments between C1 and C2?
Between C1 and C2, there is the transverse ligament, anterior atlantoaxial ligament, and the posterior atlantoaxial ligament.
So all of them forms the cruciate ligament.
Cruciate ligament, yes.
What is the movements at the atlantoaxial joint, please?
It is extension and flexion, and I think lateral extension. And I think axial rotation as well. I'm not sure. Atlanto-occipital joint.
And what
I
about
think
the
I just sorry.
what about the atlanto-occipital joint? What are the movements?
Atlanto-occipital joint. I'm not sure. And maybe just extension, flexion as well.
And we have lateral extension.
Sorry,
Lateral flexion, sorry.
lateral flexion.
So the axial rotation occurs at the level of the atlanto-axial joint, while the lateral flexion occurs at the atlanto-occipital joint. That's it, Dr. Salah. Do you have any updates or any extra questions for him? Hello, Dr. Salah.
Doctor, can you just clarify the last question about the atlanto-occipital and atlanto-axial? The movements.
Atlanto-axial is this joint between the axis and the atlas. So the movement in it is flexion, extension, and the axial rotation around the odontoid. While the atlanto-occipital is the joint between C1 and the occipital bone. So the movement in it is flexion, extension, and lateral flexion because whenever you move your neck to the sides. That's it.
Okay.
Just let me check where is Dr. Salah. I can't find him.
Hello. Yeah, بالنسبة اللجنة دي فيها updates. I think even the picture was fractured, you put it already. يعني you put the new picture also. This station came since a long time during Corona. I remember during Corona in Cairo. Since that time, not came in all centers all over the world. All over the world, that I'm telling this information, not came. تمام? So just keep this knowledge in case it will come, it will be easy. Only in other station about vertebral artery course, he can give you the atlas and the axis vertebrae to identify them. Only that. Other than this, not came since a long time. Clarify the answer. You mean which question? يعني يا شباب يعني if
The
you
question number 9. Yeah, you are correct. The movement is the axial rotation. It's the only movement because logically, if any flexion and extension occurs, the adenoid will cut the spinal cord. You are correct. And the flexion extension and the lateral flexion occurs at the atlanto-occipital joint.
تمام ماشي.
Dr. Hiba, would you unmute your mic, please?
Yes.
Hello?
Can you hear me?
Yeah, I could hear you well.
Okay.
Please, in this picture, would you identify the tentorium cerebelli and the diaphragm ocelli, please?
Okay. But they are not numbered. How can I show you?
Describe it for me. Let me point it for
Okay.
you. Go up, down, direct me.
All right. So just a little bit to the left of your arrow. Yes. This is the tentorium cerebelli.
Are you sure?
No. It's actually the line on top of it. Yes. Yes.
Yes. Here, this is the falx cerebelli in between the two hemispheres of the cerebellum, but the one which lies transversely is the tentorium cerebelli. And where is the diaphragm ocelli?
The ocelli is closer to the sella turcica, like more anterior.
Yes.
Yes.
This one. Good. Mention the attachments and blood supply of the tentorium cerebelli, please.
So it's attached anteriorly to the superior part of the petrous bone, close to the oculomotor nerve, and medially is attached to the falx cerebri.
And what is its blood supply?
I'm not sure about the blood supply actually. I'm not sure. Hello?
It doesn't have a blood supply specific for it, but it receives its supply from the blood supply coming to the surrounding structures, which are the underlying cerebellum and the brainstem.
Okay.
So it doesn't have an artery coming in, specifically to it. So it takes from the medial tentorial artery, posterior branch of the middle meningeal artery, the tentorial branches of the posterior communicating arteries. So it takes from the tentorial branches from the surrounding arteries around it. And regarding the attachment of the tentorium cerebelli, you will find it in the group definitely. So what vessel runs below the tentorium cerebelli?
I believe the petrosal sinuses.
Yes.
Yeah.
If the arrow is here, so it will be the petrosal sinus because it runs close to it or just below it. But we don't know where did the examiner specifically put the arrow, or where did he ask exactly. So you have to check the whole area just to be safe. If the patient has an injury here, pointing to the central gyrus or parietal lobe, which bone would you drill to reach the area of the injury? So the examiner is holding a brain, pointing to the area of the central gyrus and part of the parietal lobe, and he is asking which bone should you drill to reach this site.
Yes, so it would be the parietal bone.
And which artery runs under it?
The artery, anterior cerebral artery, or
The
I'm not
anterior
sure.
artery runs deep.
Superior sagittal sinus, maybe.
Superior sagittal
Oh, they need
sinus.
an artery.
Artery in the or running on the parietal lobe, or just below the parietal bone.
Not sure.
Dr. Salah,
Yes,
last time you didn't agree with the middle meningeal artery,
I agree with middle cerebral artery.
but I don't agree with it.
هقول لك يا سوزان regarding middle cerebral artery, middle meningeal artery, middle meningeal artery, if underterial, not temporal.
Actually, it has a tree of branches
Yes, I agree. In
running just below the parietal bone, and it is the first artery you encounter when you come into the skull. So it is the artery that causes the extradural hematoma. So if
yes,
we are,
Suzanne, but not asking in the temporal, asking in the parietal. يعني if sorry, if asking under parietal or anterior, I agree for that. But temporal, middle cerebral.
but the middle cerebral, I don't know, but I don't agree. Because we are now doing a drill in the bone, and they are asking about the artery below that. I have a picture I will send to you.
You mean superficial? I agree. Maybe one branch of it. يعني if
One.
يعني
Lots of
can
branches.
يعني by the way both of them يا Suzanne, I agree for both of them. But which answer examiner is waiting? يعني I agree for middle meningeal artery or branches of middle meningeal artery, this is the most superficial one, which can be injured here. But middle, because middle, it will be inside the brain, not
Yeah.
inside the brain, not superficial.
So
I agree
they
for that.
are asking about the artery runs under the bone.
Mm.
The middle cerebral artery is a deep branch.
Yes, I agree for that. But I think he's waiting this answer. Anyhow, keep in your mind if superficial you can go for it. طيب share your picture حطها على الجروب. ماشي
I send it to you in private.
ماشي. هبعت الصورة على الجروب. ماشي يلا.
When you remove the bone, the brachial bone, what is the layer you encounter?
So we will be seeing the dura mater first, and then the rest of the meninges.
The question is, what is the layer? So please be specific in your answer.
Okay, so when I remove the bone, the first layer it would be the dura mater.
Where does the arteries supply the brain run?
Extradural, epidural space.
So you have the middle cerebral artery, the circle fills in this extradural space.
Sorry?
Do you mean that the circle of Willis, which supply the main blood supply to the brain, runs in the extradural space?
No.
Where does it run?
The subdural, then? I'm not sure.
It is in the
Deeper?
deepest part of the brain, the deepest part of the cranium.
Okay.
So it's not related to the dura, definitely.
Mm.
So where does it run?
So that would be beneath the meninges then. It's deeper to the pia mater. Yeah.
Yes. Okay, what do you identify in this picture? The abducent nerve, optic nerve, and the oculomotor nerve.
Okay, so the one closer to the internal carotid or just inferior to it would be the abducent. The one below the vessel.
So this is a vessel.
Mm-hmm.
You mean this one?
Yes.
Mm-hmm.
The optic will be on top of the vessel. I mean, outside the cavernous sinus, yes.
Exactly.
And then the lateral wall of the cavernous sinus, the top one would be the oculomotor.
So it would be this one.
Yes.
Good. Brilliant. Would you identify the internal carotid artery?
Okay, yes, it's that blood vessel, the red structure.
Yeah.
No. It's yeah, it is.
Yeah. Which of them?
It's the two of them, the right and left.
Yeah, because I point to this, you told me no.
No, it is, yes.
Okay, this is the internal carotid. And where is the oculomotor nerve?
Oculomotor, just the nerve below it, not directly below it, just the one a little bit to the lateral. Yes. Yeah.
Mm-hmm. And where is the ophthalmic nerve then?
Ophthalmic division will be the one lateral to the oculomotor.
Yes, exactly. This
Yes.
big one.
Mm-hmm.
Good. What happens if the abducent is compressed?
We'll have symptoms of abducent nerve palsy. It can mainly affect the lateral rectus muscle. So we have defect on the lateral gaze.
Yes, it will affect the lateral gaze because it supplies
lateral rectus.
What happens if the oculomotor is compressed?
So oculomotor supplies a lot of muscles. So firstly, we will have the mydriasis, which is dilatation of the pupils because of loss of the parasympathetic supply from the oculomotor. And then we will have also the gaze will be defected. We will have the eye would be looking downward and outward. And we also have ptosis because we lost the function of the levator palpebrae superioris.
Brilliant. What is the first sign of oculomotor nerve compression?
It would be the mydriasis or the pupillary dilatation.
Would you speak about the false localized sign, please?
Okay, so it's a neurological manifestation that is reflecting something that is remote or distant from what we actually see on the local anatomical side of the pathology. Example for it would be the increased intracranial pressure symptoms and their manifestation.
What aneurysm could compress the oculomotor nerve?
Oculomotor? Not really sure.
Posterior communicating artery aneurysm.
Okay,
Why the upper eyelid drops with the
this is the,
oculomotor compression?
yes. So
Sorry?
the levator palpebrae superioris.
Yes. It drops because the muscle that is responsible for the elevation is affected, which is the levator palpebrae superioris. What is the structure in the neck could cause ptosis if injured?
In the neck, the sympathetic chain.
And what is the name of this condition?
This is Horner's.
How do you identify the internal acoustic meatus in this picture?
Not sure.
Listen. This picture came in Oman last exam, and they came in Cairo last exam. والحرابه مش هيعرف المك عنده وقال برضه نفس الكلام ده came in May and came in كذا هو عارفها يعني وصلت. This station this picture exactly came in Oman and came in Cairo. This picture.
Okay, I'm not sure, but maybe C.
Yes, it is C. And what nerves pass through it?
The facial and the vestibulocochlear, so 7th and 8th.
And which lesion could affect the nerves here?
Acoustic neuroma.
What?
Wait. So what is the motor affection if you have tumor here?
The motor affection could be to the nerve to stapedius of the
Yes.
facial.
Yes.
That's the motor, and also what else?
This is asked in UK.
Mhm.
You know which nerve affected?
So the facial and vestibulocochlear. So the facial
What is
is
the
nerve to
motor?
stapedius.
What is the motor would be? What is the motor affection? قوليهم بقى terminal branches of facial. He's waiting on
Okay.
facial
Yes,
expression.
yes.
يلا facial expression يلا.
Yes. Okay.
You know it. Okay.
Yes.
Good
So
luck.
everything from the injury and distal to that. So starting from the acoustic meatus and then the
Forget
the five.
stapedius now. Concentrate in about the terminal branches of facial nerve. This will be
Okay.
affected, so no facial expression. Okay.
Mhm.
So regarding the lesion, it's schwannoma and acoustic neuroma.
Okay.
Which part of the face is affected if the lesion occurs in the internal acoustic meatus?
So it would be the ipsilateral side of the face, all the ipsilateral side, because that would be a lower motor neuron.
Ipsilateral lower motor neuron, yes. What are the attachments of the falx cerebelli?
Falx cerebelli, it would be the internal occipital crest and the internal occipital protuberance. Yeah.
Continue. I'm waiting for you.
I'm not sure exactly. These are
Extending posterior from the occipital bone, anteriorly to
the ethmoid bone.
Yeah, to the area or the insertion of the tentorium cerebellum.
Mhm.
What are the attachment of the falx cerebri?
So anteriorly would be the crista galli of the ethmoid, and posteriorly would be the attachment of the tentorium cerebelli.
Yes, upper surface of the cerebellum tentorium.
Okay.
Would you identify the structure A?
A. I'm not sure about A. That's the clivus.
Yes, it is. And
The
what is
clivus?
congenital malformation? Yes, it's the clivus.
Yes. Okay. The congenital is there is the platybasia, which is flattening of the clivus.
Yes, this is the most common congenital anomaly.
Mhm.
What part of the brain lies on it?
The occipital lobe. Not sure.
The bones.
The pons. Okay.
What is the most aggressive type of glioma?
The glioblastoma multiforme.
And where does the CSF located?
So it's found in the ventricles of the brain and also in the subarachnoid space, around the brain and around the spinal cord.
If a lesion arises from the central gyrus, which part of the skull would be invaded?
The parietal bone.
What is the artery supplies the medial region of the brain?
The anterior cerebral artery.
Are you sure?
Yes.
And what about the medial region of the brain?
Oh. So the middle region would be the middle cerebral, but the medial would be the anterior cerebral.
Exactly. Middle by the middle, medial by the anterior. How does the intracranial pressure, high intracranial pressure, cause papilledema?
Because the high intracranial pressure will be transmitted through the meninges surrounding the optic nerve.
So you have to mention first that the optic nerve is surrounded by the 3 layers of the meninges, which transmit the pressure from the intracranial space to the eye, causing the papilledema. What part of the ear contains the auditory ossicles?
The inner ear.
Which part of the middle cranial fossa forms the roof of the middle ear?
It is the tegmen tympani.
If infection spreads from the middle ear, in which part of the brain will abscess be formed?
The temporal lobe.
Mention the possible routes of spread of infection from middle ear towards the brain, please.
So it could be through the direct invasion of the bone. It could also be through migratory thrombophlebitis by the emissory veins. And lastly, it is through the inner ear through the cochlear aqueduct.
And through the mastoid air cells, causing mastoiditis as well.
Okay.
So they are 4, not only 3.
Four.
If there is
Okay.
infection in the middle ear, which cavity rather than the tympanic membrane could be affected?
Yeah, so it would be the mastoid air cells, the mastoid antrum.
Exactly. Which cranial nerve passes during its course between the tympanic membrane and the mastoid air cells?
Air cells? The facial.
How does infection spread from the face towards the cavernous sinus?
It's spread through the ophthalmic veins, superior and inferior ophthalmic veins, the facial vein, and yeah.
Yes. And emission pulseless veins. What are the clinical signs of cavernous sinus thrombosis?
So it will be painful, swollen eye. It would have also the cranial nerve pulses. It can have ophthalmoplegia. It could be also Horner syndrome because of the sympathetic of the internal carotid.
Which cranial nerves pulse?
Third, fourth, oculomotor trochlear, and also maxillary ophthalmic division of mandibular and abducent.
What else?
And the sympathetic involvement causing Horner
What
syndrome.
else?
Other nerve, you mean, or other symptoms?
Other symptoms, other signs.
Papilledema.
What else?
Proptosis of
Papilledema
thalmoplegia.
doesn't occur usually unless there is increased intracranial pressure. So it occurs only in severe cases, but there could be gradual loss of vision and signs of meningitis. Would you mention the external muscles of the tongue and their nerve supply, please?
The styloglossus, hyoglossus, palatoglossus, and genoglossus. They're all innervated by hypoglossal nerve, except the palatoglossus, it's by the vagus.
What are the sensory nerves in relation to the internal carotid artery?
I couldn't understand the question.
Sensory nerve have relation anatomically to the internal carotid artery.
Anatomical, so the ophthalmic division.
Yes. What do you name the red structure?
This
This depression.
the central sulcus.
Yes, exactly. Name the loops anterior and posterior to it.
So the frontal and the temporal.
Yes. Which artery runs in it?
Middle meningeal. Not sure.
Middle meningeal runs over in the extradural space over the dura. So definitely doesn't run here. So which one is it?
Middle cerebral.
Yes. It's the middle cerebral artery. What do you name the green structure or groove? Yes.
Parieto-occipital sulcus.
Yes. This is a combination of 3 stations. It's not only 1 or 2 stations. There are collected 3 stations, so you do not be worried that there will be 40 questions in one station. Usually the maximum number is 20 per station, and it depends on your luck. Sometimes there are very short stations in which you could lose a lot if you answer one question incorrectly, but most of them are 20 questions. Dr. Salah, would you like to add anything for her? She did great. I think I tested all her neuroanatomy.
This is not a new station. Makes you frustrated. This is your problem, not our problem, because this is done in the smoke. حلو جدا الكلام ده. خلينا بقى ندخل بقى تفك شمال. ماشي. What is this is neuroanatomy. Most of the pictures shared from the real exam. You have the pictures. Most of the new questions discussed. Posterior communicating is an aneurysm asked before. مش قصدي حاجه. يعني ايه long station? You don't know what is going now. Sometimes they are bringing two stations and mixing them together. The way هبه she is answering now is amazing. Why? سوزان خدتها شمال يمين راحت فوق تحت وهي ماشيه ثابته. This is exactly what is going in exam. Exam will not come like you are thinking. I want 20 questions for the mock for this station. I will go and find them. No, not coming by this way. They started to mix the stations. This is not new station. This is about 2 or 3 stations. يعني I remember and all the answers, by the way, all the answers from the checklist, most of them. Okay, the pictures shared very important. This station very bad for some people, but really we shared all the new pictures, in this station. تمام يا شباب؟ You have any question not clear? Sorry, Suzanne. You have any question not clear? سبعة وثلاثين يا سودان. Suzanne, what is this question?
Easiest question in this station, the lobes anterior and posterior to the central sulcus, the frontal anteriorly and the parietal
Precentral, post central,
and
precentral.
the temporal. Yeah.
ماشي.
Parietal and frontal, and she answered them clearly and correctly.
What is the vessels? Which vessel? 35.
All the middle cerebral artery. And the sensory nerve in close proximity to the internal carotid artery is the ophthalmic nerve. واضح جدا إنه كله جاي يكتب nobody would like to participate. Now we don't have any new participants.
نعم.
كله جاي يكتب يا دكتور صح كله جاي يصرف. Mia image.
Yes.
Hi.
Hi,
Nick.
yeah, nice to meet you.
Yeah.
Yes, you can call me Nick.
All right. So I was
Yeah.
trying just to pronounce it correctly.
Yeah.
Okay. So would you tell me what is the structure with the red arrow, please?
The structure indicated by red arrow is the esophagus. So
And
the
also the
epithelial lining,
lining and blood supply, please.
yeah, the epithelial lining are the nasal squamous epithelium. The blood supply anterior one is supplied by the inferior thyroid artery, which came from the thyrocervical
Excuse me.
tract.
Would you speak up and repeat the answer from the beginning? I can't hear you well.
Oh, yeah. Can you hear me now? Yeah. Sorry.
Your voice is a bit far. I don't know why. So if you speak up or come in proximity to the device, your
Yeah.
will be more helpful.
Okay. Yeah. Sorry.
Yeah, it's
Now,
alright.
how about now?
Yeah, it's better now.
Yeah. So the epithelial lining is the starobine squamous necrorenal epithelium. The arterial supply, upper one third of the esophagus is supplied by the inferior thyroid artery. Middle one third of the esophagus, middle one third supplied by the branches from the aorta, and lower one third is supplied by the left gastric artery. Yeah.
Yeah, we told before, whenever they ask you about the blood supply, you have to mention the
Sorry.
arterial and venous, please.
Venous, the venous drainage are the superior and inferior esophageal vein drain into the middle thyroid. Sorry, please. I want to get it. Yeah.
I can't hear you well, really.
Oh yeah. Sorry.
I told you I want to skip this question. No,
Yeah.
he's talking in English. I can understand him. You are from where, my dear? From Malaysia?
Sorry.
You are from where? You are from where?
Where are you from now?
Now I am from the UK. Can you hear me now?
Now your voice is more clear.
Oh, sorry. Yes. I use the Bluetooth device. So the device became the error.
You started with a clear voice, then the voice started to be very low. I don't know what's wrong with it.
How about now? Yeah.
It's all right now. Just keep it the same tone.
Yeah. Sorry. Maybe there's an error in my device. Yeah.
So would you tell me what you were telling? Because I didn't get you.
Can you hear me well? Hello?
Now I can hear you, but what you told previously regarding the answer, I didn't get it.
Oh, sorry. Yeah. So I need to do I need to answer again?
Yes, please, because I didn't get your answer.
Okay. Yeah. The arterial supply of the esophagus are upper one from the inferior thyroid artery, middle thyroid from the aorta, and lower one from the left gastric artery. The venous supply are the upper upper water from the inferior thyroid vein, and middle water from the mediastinal vein, and lower water to the left gastric vein.
And what is the anastomosis around its lower third?
So there is a photosystemic anastomosis around it's a lower water.
Between which vessel does it occur?
Yeah, it's between the left gastric and esophageal vein.
And what is the pathology that could occur here in this area of anastomosis?
Esophageal varices due to the portal hypertension.
Yes, exactly. So the anastomosis of the port to systemic anastomosis occurs between the left gastric vessels and the azygous vein, and the pathology is the esophageal varices. Perfect. What is the structure which with the yellow arrow here?
It's a carina
And what is its vertebral level, please?
and T4.
Yes, it's T4. Which nerve passes to the either side of the trachea in the thorax?
Vagus nerve.
Yes, it's the vagus nerve. Please, would you identify for the brachiocephalic artery?
Brachiocephalic artery is number four.
Sorry, say it again.
Sorry, brachiocephalic artery is number 4.
Yes, it's
Yeah.
number 4.
Right carotid artery 21. Left carotid artery 14.
Mhm.
Subclavian artery, right subclavian artery 19. Left subclavian artery, I can see it.
Wait.
Sorry.
Which number is the right
Oh.
carotid artery?
Right carotid artery, number 19. 19, yeah.
So what is the number for the right subclavian then?
18.
Here, it's
Oh,
21.
21, sorry, yeah.
It's 21. Because here we have the brachiocephalic which bifurcate to give the common carotid artery and the subclavian artery. And
Yeah.
where are the vagi, vagus nerve in both sides, please?
Yeah, from the right vagus, it can around the 20, number 20, yeah. And the right vagus may be 15.
The right
Yeah, right is
vagus is 21. It's coming from the neck coming down to hook around the subclavian, right subclavian, and go back the recurrent laryngeal. So 22 is the vagus, 20 is the recurrent laryngeal, right recurrent laryngeal, and we have 15 here is the left vagus nerve. Good. From where does the subclavian artery originate in both sides, please?
from the right subclavian artery originated from the right brachiocephalic artery, while the left subclavian artery is directly originated from the arch of aorta.
Yes, right from the brachiocephalic, not the right brachiocephalic, because we have only one brachiocephalic, which is the innominate artery, because it's only one. Which part of the brachial plexus crosses the first rib posterior to the subclavian artery?
Lower trunk of the brachial plexus.
Sorry?
Lower trunk.
Lower trunk, yes. And what is the subclavian steal syndrome, please?
Subclavian steal syndrome. This is the retrograde blood flow of the blood from the subclavian vertebral artery to the subclavian artery of the contralateral side, which were, yeah.
Sorry, I didn't get it. Would you explain it more clearly, please?
Yeah. Subclavian syndrome, C syndrome is the venous occlusive syndrome. The blood flow from the blood retrograde flow, the retrograde blood flow from the subclavian artery into the vertebral artery due to the occlusion in the subclavian artery proximal to the vertebral artery.
So it is a neurological syndrome or neurological manifestation that is manifested with syncope or dizziness or loss of consciousness when the patient do exercise with the upper limb because of what we mentioned now. There is blockage in the vertebral artery proximal to the blockage of the subclavian artery proximal to the origin of the vertebral artery. So the blood will be shifted to the upper limb instead of going to the brain, which causes shortage of the blood supply, causing that neurological manifestation. And what is the thoracic outlet syndrome?
I want to scale it.
The
Can I
thoracic
scale it?
outlet syndrome is a neurovascular syndrome manifested with the affection of the brachial plexus along with the vessels, which are the subclavian arteries, due to something blocking the thoracic outlet like cervical rib, tumors, or whatever.
Thank you.
How, just a minute. How does a bronchial carcinoma causes hoarseness of voice?
So, by invasion of the vocal cord or invasion of the recurrent lesion,
Either direct invasion to the cords or to the nerve supply to it, to the recurrent laryngeal. Brilliant. Would you identify the recurrent laryngeal nerve here in this picture, please?
Yeah, on the right side, is it 21? Is it 20? Yeah, sorry.
20, yes.
Yeah.
Down
On the left side, I think I can see it.
Yes, it's
Only
not
picture, yeah.
But where does it hook exactly?
On the actual aorta.
Yes, around the arch of the aorta. Perfect. What is the structure number 11? This
Is it the isthmus of the thyroid gland?
And what is its arterial supply?
Thyroid glands are supplied by the superior thyroid artery, which are the branch of the external carotid artery. So inferior thyroid artery with a branch of the thyrocervical trunk and thyroid enema directly from the aorta, yeah, and venous drainage, superior thyroid vein, inferior middle thyroid vein, and inferior thyroid vein.
Where does the superior thyroid go?
Superior thyroid and middle thyroid vein go into the interventricular vein and yeah. Inferior thyroid vein go into the left brachiocephalic vein.
Yes, exactly. All the inferior thyroid go to the left brachiocephalic, while the superior and middle goes to the internal jugular vein. Well done. How many parathyroid glands are we usually have?
4 parathyroid glands there.
Would you identify the upper trunk of the brachial plexus in this picture, please?
In this picture. Sorry. 32.
Sorry?
I think 32. 32. Oh, sorry.
Here.
Oh, sorry. Yeah. 35.
What injury could lead to arm flexion, loss of abduction, and wrist extension?
It's an up palsy.
Yes.
C18.
Palsy, which is injury to the upper cord of the upper trunk of the brachial plexus. Where do the carotid body and carotid sinus locate?
Carotid body located in the posterior surface of the bifurcation of the common carotid artery. Carotid sinus located at the immediate superior to the bifurcation of the internal carotid artery.
Yes, so here the area of the bulge is the carotid body and the carotid sinus here at the bifurcation. What is the function of each of them?
Carotid body is responsible for the chemoreceptor. Carotid sinus for the baroreceptor.
Yes, so the carotid body responds to the change in the pH and the carbon dioxide level, and the carotid sinus respond to the pressure, blood pressure.
Yeah.
Because of that, we use the carotid massage when the patient have sinus tachycardia to give a false signal to the carotid sinus to the heart to slow down. Which nerve lies just lateral to the external carotid artery?
It's a hypoglossal nerve.
What is the deficit could occur if it's injured?
Yeah, there will be the SV lateral loss of the muscle function of the tongue.
Sorry, say it again.
Loss of function in the SV lateral side of the tongue. Loss of muscle,
So it will
motor
be
function.
paralyzed.
Yeah.
The ipsilateral part of the tongue will be paralyzed. There will be it will be wasted, and there will be some fasciculation. And when we protrude the tongue out, what sign will you find?
The tongue will be protruded to the contralateral side.
To the affected side, not the contralateral side.
Oh, sorry, yeah. Fantastic.
Pointing to the facial artery, could this structure be ligated without developing ischemia to its target organs and tissues?
Yeah, we can ligate the facial artery because there are a lot of anastomosis from the contralateral side.
Could you mention example for that anastomosis?
Facial artery anastomosis. Yeah. Sorry?
Could you give an example of these lots of anastomosis? Give me an example.
I want to get it.
There is direct communication between the ophthalmic artery, which is a branch of the internal carotid artery, with the facial artery, which forms one of the anastomoses between the external and internal carotid artery, along with the network of anastomosis between the branches of the external carotid arteries in both sides. Pointing to the submandibular gland, where does its duct open?
Submandibular gland that open on the floor of the mouth beside the frenulum.
Yes, around the perineum. Pointing to the parotid gland, where does its duct open?
That's all the parotid gland open at the upper molar teeth, yeah, opposite to the upper molar teeth.
Opposite to the second molar
Molar
teeth.
teeth, no? Yeah.
Not accepted. This answer not accepted. So, where is the parotid duct opening? Again,
Opposite to the second molar teeth, no?
not accepted. You told me opposite to the second upper molar tooth. I agree, but not accepted. Complete your answer.
Sorry. I don't know about that, yeah.
Where is the duct is run? Where is run? You should mention that the duct is run over the masseter and the piercing the vaccinator to open in the second upper molar teeth. Okay?
Yeah.
Putting this answer.
Or they can tell that it opens on the inner surface of the cheek, opposite to the second molar tooth.
He should
or
mention
maxillary molar.
this is going anterior to the masseter, piercing vaccinator should be mentioned these two before going to be open in the second upper molar teeth. Okay? No.
What is the type of its salivary secretion, please?
Serious type of secretion, yeah.
Sorry, say it again.
Serious type of secretion,
Yes.
serious, yeah.
Back, Susan, back for this picture again. Sorry. Back. So you can see where is the carotid sinus again?
Carotid sinus, yeah.
Could you point for me where is exactly?
Superior to the bifurcation of the internal carotid artery.
At which vertebral level is this bifurcation?
C4.
Okay. This question asked recently. If you will do palpate in this area and dropping your hand here, what will happen?
The patient will be faint, loss of conscious.
Why?
Because
This question is new يا شباب. This question is new. If you're rubbing the neck in this area,
yeah,
what patient will have?
basal, single basal bigger reflex.
Why you are doing massage here? Why you are doing massage here? Bradycardia, excellent lead.
Yeah.
Bradycardia. Mechanism may be asked. So carotid massage will increase the pressure on the carotid sinus. So we increase the stretch. Increasing stretch will increase the afferent baroreceptor firing. Increase afferent baroreceptor firing will increase AV node refractory period, and this will cause bradycardia. I will share the picture from part A. Okay, this is very important paper because carotid massage asked recently. يلا كمل يا سوزان.
What are the boundaries of the posterior triangle of the neck, please?
With the boundary of the posterior triangle, then anterior bora is the posterior bora of the sternocleidomastoid muscle. Posterior bora is the anterior bora of the trapezius muscle, and lower bora is the middle third of the clavicle.
Yes, exactly. And what are the muscles supplied by the accessory nerve? How to test each of them? Repeated question. Would you
Yeah,
answer it, please?
accessory nerves apply the sternocleidomastoid muscle and trapezius muscle. To test the trapezius muscle, I will ask the patient to shred the shoulder against the resistance.
سوزان مش لازم نهايتها بقى خلاص.
Oh, yeah.
Do you identify the omohyoid muscle, please?
Omohyoid muscle, superior value is 54, inferior value is 21. Next apply. Oh, sorry.
Yeah, it is a repeated question because of
Yeah.
that I passed it.
Yeah.
Would you identify the posterior belly of the digastric?
Yeah, 48.
Then these questions are repeated. If repeated خلاص بصين.
We didn't identify it before, but it's all right. What is the structure number 27? This one.
Sorry, I want to skip.
It's the lingual nerve. And what happens if injured? We mentioned it before.
Yeah.
What do you mention? The intrinsic muscle of the tongue, we mentioned that. Which muscle is responsible for the tongue elevation and what's its nerve supply? We mentioned that as well.
Yeah.
Which blood vessel could bleed if perforation of middle esophagus occurs during oesophagoscopy?
Aorta.
Sorry?
Aortic branches from the aorta.
I didn't get it. Sorry, say it again.
Middle esophageal.
Which vessel is it?
Oh, it's like a vein, yeah.
Yes, it's a zygous vein. Aorta is lying deeply, and it's so muscular, so it's very difficult to perforate it before perforating the zygous. We have done. Dr. Salah, do you have any extra questions for him?
Yes. Couldn't hear what? بصوا يا شباب. I think Dr. Suzan, she is repeating his answers. I know maybe his accent not clear for all of us, but I think Dr. Suzan, she is repeating all the answers. تمام? I
Yeah.
have only one question for you. This is new question. You can, if you have picture for branches, is the picture I think shared by Dr. Suzanne about the arch of aorta subclavian vertebral. You can identify vertebral artery.
Sorry.
You can identify vertebral artery.
Vertebral artery.
Yes. Sorry, Suzanne, أنا هوقف
I don't. I think I cannot identify the vertebral artery because the vertebral artery pass to the foramen transverse.
I stopped sharing if you would like to share it from your device, Dr. Salah.
أشيلها من عندي؟ شير؟
Yes, please. If you have the picture, please share it.
Okay. I have the feedback came from UK about these two pictures. They told me the picture is close to this. I think this very bad picture. Okay. If you will start first for the arch of aorta, you can identify left subclavian and left common carotid. Left common carotid, as you see, is going up. It will be clear with you. It will be clear with you. صورة سيئة جدا على فكرة. Okay. So this is the left common carotid, and this is the subclavian. The first branch of subclavian is what? The first branch is vertebral. This is the vertebral. This is the vertebral, very important.
Yeah.
And you will find the cervical oscid and the internal memory. This oscid also internal memory is going down. This all branches of subclavian artery. It's the first time to ask it about internal memory, vertebral, and the thoracocervical. These three branches asked recently. We have another picture. One of these two pictures, by the way, the feedback came for me. I think here it's difficult to identify the cervical, no, sorry, not cervical tract. Here you can find also again the internal thoracic or internal memory. This branch of what? Of subclavian. This is subclavian again. This is subclavian, and here is the first branch is what? Is vertebral up. Okay, so please keep these branches we came before. This picture only was new. Tell us, Susan. Next. Pictures are close to it, but this is not the real picture of exam, but close to it. This all the updates in this station.
Dr. Razi?
Hello.
Hello.
Assalamu alaikum, Dr. Suzan. Is my voice clear?
I can't hear you well.
My God. Is it okay now?
Yes.
Yes.
Better now. There was some echo at the beginning. Okay, the easiest station in this mock. Could you identify the organ in the picture, please?
Yes, it's thyroid gland.
Mention the different parts of it, please.
It has right and left lobes and isthmus.
And in 10%, we have the pyramidal lobe. Speak about the blood supply and nerve supply of the thyroid, please.
Yes, the thyroid gland is the arterial supply is from superior thyroid artery, the first branch of external carotid artery, and inferior thyroid artery from the thyrocervical trunk of branch of subclavian artery, and thyroidema, which comes from the brachiocephalic trunk or arch of aorta, and the venous drainage is superior and middle thyroid veins into the internal jugular vein, and inferior thyroid vein into the left brachiocephalic vein. And the nerve supply is from three cervical ganglions, superior, middle, and inferior. And the middle cervical ganglion usually acts responsible for the secretion from thyroid gland.
What about the embryologic development of it, please?
Okay, thyroid gland develops from foramen cecum and passes backwards and forwards to loop around beneath the hyoid bone. And should I mention any abnormalities in its development?
Sorry, say it again. I didn't get your answer.
Okay, so thyroid gland develops from foramen cecum and passes backwards and loops around beneath the hyoid bone.
Yeah. So, what is thyroglossal cyst?
Thyroglossal cyst. So thyroglossal cyst is a fibrous cyst which forms from the leftover of leftover the material during the developmental stages, and it's usually complicated by infection.
Yeah. So the thyroglossal cyst occurs when there is no full obliteration of the pathway of the descent of the thyroid. By the way, regarding the nerve supply of the thyroid, we have also sympathetic supplies through the superior, middle, and inferior sympathetic ganglia. We have parasympathetic through the superior laryngeal and recurrent laryngeal nerve as well, as the secretory which you mentioned. Would you speak about the course of the superior thyroid artery, please?
Superior thyroid, it originates from the external carotid artery and passes downwards and reaching the apex of the lobe of the thyroid gland. And before that, it gives a branch which is superior laryngeal artery.
Yes, exactly. Which muscles should be divided to expose superior thyroid artery during thyroidectomy?
It's omohyoid and sternohyoid muscles.
Which of them again? Sorry.
Omohyoid muscle.
Which part of the omohyoid?
Superior belly of omohyoid muscle.
What else?
Else. Sternohyoid muscle.
What else?
Thyroid.
Sternothyroid as well.
Yes, it's
Because the
sternocleidomastoid.
sternothyroid
Yes,
attached to
yes,
the thyroid cartilage. So we cannot
yes,
access it unless we divide it as well, right?
yeah, yes, Doctor. Sorry.
What is the nerve at risk during ligation of the superior thyroid artery?
The recurrent laryngeal nerve.
And what is its clinical picture?
Oh, so for the sensory deficit, it will be loss of sensation below the vocal cord, loss of sensation of the mucosa below the vocal cord, and the motor will be unilateral or bilateral, maybe partial or complete. So if it's unilateral, then it will be respiratory compromise, and if it's bilateral, then there may be a stridor and dysphagia, and if it's partial, then there may be hoarseness of voice, and if it's complete, then it will be loss of voice or aphonia.
Okay, the nerve runs in proximity, in close proximity to the superior thyroid artery is the external branch of the superior laryngeal nerve, and the affected or the clinical picture is the loss of the high-pitched voice. We usually ligate, or we are at risk to ligate the recurrent laryngeal nerve when we ligate the inferior thyroid artery or the superior. Would you identify both vagi? I believe we answered this question. Right, the axis is 21 and the left is 15, and the recurrent laryngeal nerve is 20, and the
22.
side is not in this picture. What does the recurrent laryngeal nerve supply?
The recurrent laryngeal nerve supplies all the other laryngeal muscles except cricothyroid, and its sensory innervation is of the mucosa below the vocal cord.
Exactly, correct. What is the autonomic innervation of lower third of the esophagus?
Sympathetic plexus.
Sorry?
Esophageal plexus.
Yes. But what is the source, or what type of supply comes here to the esophageal plexus? Mainly from
It's
the vagal trunks and mainly the posterior trunk. That's it, Dr. Salah. Do you have any extra questions for him, please?
No, he's doing great, by the way. Regarding of the question about which nerve you told in when you are doing ligation for the superior thyroid artery, answer is what?
Dr. Salah, I told a recurrent laryngeal nerve,
No,
but
it's wrong. She corrected for you.
yes, it's external laryngeal branch of
So,
superior laryngeal
which
nerve,
muscle supplied by it?
which it supplies cricothyroid muscle.
Okay, okay. I think they want this only. This station is very clear, and the embryological defect for thyroid also asked here also. So it's like cerebrossal cyst. What is a cerebrossal cyst? And the pyramidal thyroid asked here also. تمام Suzanne? This is all in this station. Nothing new.
Thank you, Razi. You did
Thank you,
great.
Dr. Suzanne.
Dr. Tariq, would you unmute your mic, please?
I think
Hello.
Hello, Dr. Suzan.
Susan, I think I have another question.
I don't know whether the problem is from my device. I can't hear any of you.
Can you hear me?
No, not clear.
Voice is very, very, very low, Dr. Tariq.
Hello?
I can't hear you, really.
Susan, we finished from a station of the motor. I think we finished from it.
I believe yes.
Yes. Okay. So, oculomotor policy, you will tell what is the affection of oculomotor. You will tell everything about oculomotor, like dilated pupil, diplopia, and ptosis. Okay, شباب, like ptosis. So another question asked, what is in neck can cause ptosis? What is the region in neck will cause ptosis also?
Yeah, I believe Hiba answered this question when I asked it.
You asked him?
Yes.
هعملهم بس مش عليه. About anterior cerebelli, which structure below it? About anterior cerebelli attachment, what is the structure? The vessel below it? It's superior petrosal sinus. Superior petrosal sinus. This is the answer you were trying to answer it before. So I'm doing mention for this message again because this is our new question asked recently also. ماشي كمل يا سوزان.
Dr. Tariq, did you manage to raise your voice?
Yes. Now, can you hear me?
It's really very low. It's better than before, but it's still very low.
Okay. Hello?
Hello?
Yes. Now it's okay?
Yeah, it's too much better.
Yes, okay.
Would you speak about the surface anatomy of the parotid gland, please?
Okay, there is upper border between 2 point mastoid and the tragus of the ear. Anterior border from the tragus to the posterior border of the masseter. Then from the posterior border, middle of the masseter to 2 cm below and behind the angle of the mandible. The lower end from the 2 cm below the angle of the mandible to mastoid.
And would you speak about the surface anatomy of the parotid duct, please?
Yes, this is imaginary line between the tragus of the ear and the angle of the mouth, middle third.
Medial or medial third?
Middle?
Yes.
Oh.
Where does it open?
In the vestibule of the mouth, opposite the second upper molar tooth.
I believe you were with us and you listened to the answer Mr. Dr. Salah mentioned. Did you?
Yes, yes. Anterior, just anterior to the masseter, then piercing the buccinator muscle.
Yes. And then it opened wherever you mentioned. What is the differential diagnosis of parotid swelling?
Maybe infection, parotitis, or mumps. Maybe duct obstruction by calculus or external compression. Maybe a tumor, benign or malignant tumor. Maybe lymph node enlargement.
And maybe connective tissue disease in form of sarcoidosis or
Sarcoidosis, yeah.
Wilson syndrome.
Yes.
What is the most common benign parotid swelling?
Polymorphic adenoma.
And what is the most common malignant parotid swelling?
Mucoepidermoid carcinoma.
And where does the facial nerve exit the skull?
Stylomastoid foramen.
Would you demonstrate the terminal branches of the facial nerve on a model or on yourself?
Yes, forehead there is a temporal branch, then zygomatic branch, then buccal branch, then marginal mandibular, then cervical.
Yeah, so you will put your hand over the face, the side of the face, and spread your fingers to the points you just mentioned. What are the other branches of facial nerve rather than the terminal branches?
There is branch inside the facial canal and like nerve to stapedius, chorda tympani, and the greater petrosal nerve. And also there is branches after coming from stylomastoid foramen, like nerve to nerve to stylohyoid, and nerve to posterior belly of digastric, then a nerve to occipitofrontalis, posterior belly of occipitofrontalis.
Posterior auricular, giving the occipital belly of the occipitofrontalis. Which muscle is supplied by the facial nerve after leaving the facial canal rather than the muscles of facial expression?
Yes, posterior of digastric and stylomastoid. Then what?
Stylohyoid.
Stylohyoid, yeah. Stylohyoid and occipitofrontalis, posterior belly.
Yes. Where to palpate the facial artery pulse?
The angle of the mandible just anterior to the masseter muscle.
Good. What does the greater petrosal nerve supply?
Lacrimal gland.
Yes, it does. Okay, that's it. Well done, Dr. Salah. Would you like to add any question for him?
No. He's doing great, by the way. And this station, I want all of you to know all the branches of facial nerve. Sensor branch. What is the sensor branch of facial nerve? اسمه ايه؟ Sublingual what?
Auricular branch.
Yes, sublingual what?
Ear lobule.
لا. External acoustic meters.
External acoustic meters.
Yes.
By the way, this is asked in part B also. This is asked in part A, sorry. So please keep all the branches of facial nerve will be asked in this station. I shared it already from notes, Salah notes in part A. Asked in this station. This station came before with actor, and they will ask you to demonstrate on the actor or draw on the actor. Okay. Yeah, next.
Thank you, Dr. Tariq. Dr. Bayezid.
Hello, Assalamu alaikum.
Please, Dr. Bayezid, would you identify the structure? Number one.
Number one is azygos vein.
Number three.
Number three would be the sympathetic trunk with
And number 24.
superior vena cava.
And number 27.
Number three is the branch of the sympathetic trunk, and number 27 is the sympathetic trunk with ganglion.
That's it. What is the boundaries of the posterior mediastinum?
The posteriorly there will be vertebra. Anteriorly there will be the pericardium, and on the both side there will be mediastinal pleura. And superiorly will be the transverse thoracic plane, and inferiorly will be the diaphragm.
Yes, exactly. What do you name 6 structures lie within the posterior mediastinum?
Posterior mediastinum will be the esophagus, the thoracic aorta, the azygos vein, the sympathetic chain, and so I can't the other one.
Yeah, you have azygos, hemiazygos, esophagus, thoracic duct, descending aorta, and sympathetic trunk and vagi.
Yes. Sorry.
What are the complications of perforated esophagus?
There will be mediastinitis, also emphysema, pneumonia.
Yes.
Abscess.
What is the type of epithelium lines the esophagus?
It is non-keratinized, stratified squamous.
What level does the esophagus begin at?
Begin at the cervical 6 level, and the bony landmark is the cricoid cartilage.
Brilliant.
No, go back, Suzanne. Go back for this picture. Okay. You told me everything about esophagus. Could you identify esophagus in this?
The esophagus,
Which number?
I can't see. Number 6, maybe.
Where is 6? It's number 8.
Okay.
Ask it. Okay. So structure number دكتور سيد هعيدهم معاه تاني معلش. Structure number 13. 13 1 3. What is this?
Sorry, come again.
13 1 3.
This one here, the small structure. Yeah.
Oh, sorry. This one is the vagus.
Yes. This
Yes.
why I was insisting. They asked in this picture or another picture similar to it. Esophagus اكتبوا عندكم بقى. Esophagus, phrenic, azygos, vagus, and recurrent laryngeal.
Yeah, but this one is the
I
phrenic,
think
not
this
the
is phrenic.
vagus.
The phrenic. The
لا
vagus.
ده
13 is the phrenic, right? Phrenic, not the vagus.
Yes, phrenic. It's a phrenic. I know it's
Yeah,
phrenic.
but he mentioned Vegas.
لا ما قلتش فيجاس. انا ما قلتش فيجاس.
لا هو قال وانت قلت له ايوه.
ما قلتش ايوه يا بنتي.
They
انا ما قلتش
accepted
أيوة.
it as the answer.
يعني سوزان يعني انا هساله اقول له هو فين الفرينك ومش عارف ان الفرينك 13 ده انتيرو. This is anterior for the hilum. Anterior to the hilum is phrenic. Vegas is posterior. اهدي شويه كده. انا بقول ايوه انا افتكرتها كده اسئله مش قصدي حاجه. 13 انت هتعمل زي الناس ما صدقت وزيدك على غلطه.
لا
اصبري
يا
اهو.
دكتور صلاح، ما احنا هنكفي له هيبتدوا يسالوا له. دكتور صلاح قال كده.
لا انا هعيدها
خلصنا
تاني.
دلوقتي.
هعيدها تاني. Number 8 is esophagus and asket. Okay.
Yeah.
Number 13 is phrenic and asket. Number 1 is very clear, which arching over the hilum. So this is what
The azygos.
azygos. Okay, I think we have another picture for him azygos. asket also.
Yeah, but in the left side.
في الصورة الثانية. طيب. Then we'll ask you about the Vegas. What is the Vegas here?
The
Vegas
vagus.
posterior to the hilum. Go posterior to the hilum. You will find it behind the hilum. It's 19.
19.
By a very clear way. This we will not be confused about them. في كمان الريكرنت laryngeal بس مش بقى في الصورة ديت recurrent laryngeal.
No, because the right recurrent laryngeal hooks up.
Yes, hooks up. I think it's not in this picture. So please keep these structures will be asked beside what Dr. Suzan asked. يلا نكمل. Continue.
What part of the diaphragm the esophagus passed through?
The esophageal opening of the diaphragm, which is produced by the right crust of the diaphragm.
So the part of the diaphragm is the right crust. Which structure accompany the esophagus?
Both the vagus nerve.
Yeah, and what do they supply?
They supply the larynx, esophagus, and whole of the GIT up to the point, the right 2/3 and left 1/3 of the transverse colon. It also supplies the pancreas, gallbladder, spleen.
So it doesn't supply the left part of the colon and the distal GIT. What is the blood supply of the esophagus? This is a repeated question. What is its lymphatic drainage, please?
The upper part, it drains into the deep cervical lymph nodes. The middle part, it drains into the mediastinal lymph nodes. And the lower portion drains into the left gastric and celiac group of lymph nodes.
What is the nerve supply to the lower part of the esophagus?
The sympathetic by the sympathetic chain and parasympathetic by the posterior vagal trunk.
Yes, forming the esophageal plexus. Mention two structures leave indentation in the esophagus.
The arch of the aorta, the left bronchus, also the left atrium.
What is the most common esophageal tumor?
The squamous cell carcinoma.
What happens in Barrett's esophagus?
In bad esophagus, there is intestinal metaplasia, which means the squamous epithelium is replaced by the intestinal type of columnar epithelium.
And what levels of spinal cord does the sympathetic trunk contribute to?
The thoracic 1 to lumbar 2.
Yes, it's thoracolumbar, so it involves all the thoracic and the first two lumbars. What communicate the spinal root to the posterior ganglionic fibers?
The gray and white rami communicants.
Yes, and ganglions, definitely. What are the tributaries of the azygous system?
The hemiazygous and the accessory hemiazygous, then the right superior intercostal veins, the lumbar veins, the pericardial esophagus, mediastinal, also bronchial veins, and the lower right posterior intercostal vein.
So we have pericardial, mediastinal, esophageal, bronchial. We have right superior intercostal, lower right posterior intercostal veins. We have as hemiazygous and accessory hemiazygous. There is no lumbar because one of your colleagues before mentioned the same. Would you identify the structures named in letters, please?
Yes, the number C is the azygos vein. Number A is the sympathetic chain. And number B is the branch of the sympathetic chain, which may be branch to the greater splanchnic nerve.
Continue, please.
Also, in here, the D is the esophagus. The A, then A would be the posterior, so it will be vagus. Then B, I don't exactly sure what this is. And C would be the phrenic.
And what is B?
I think
between the arch of the aorta and the pulmonary trunk.
Yes, the embryological remnant.
Ductus arteriosus.
Yeah, sorry, I almost forgot that.
Would you mention the branches of the ascending thoracic aorta?
Yes, the mediastinal arteries, the pericardial, bronchial, esophageal, and the superior phrenic.
That's it. Dr. Salah, would you like to add any question for him?
Go for previous picture again, Suzanne.
Yeah.
You have another picture. معاك في صورة تانية.
This one.
Okay. I think this picture we discussed. This is a picture of real exam.
I have a third one in another station. If you would like to.
أنا عايز أشوف اللي فيها recurrent laryngeal. I think the next one. The picture with recurrent laryngeal. This one. You agree?
Yes.
So, which structure is the recurrent laryngeal here? Is D. You see, it's arching. It's arching and going back. Okay.
It depends. If the arrow reaches the structure, it is the recurrent laryngeal. If it doesn't, that means the esophagus. As he mentioned.
The structure A, this is vagus.
Yes.
A is vagus. تمام?
Okay.
This A is vagus. And I think is arching back is the recurrent laryngeal. B هو ده وقته يا فاطمة؟ طيب. Ligamentum arteriosa. The most important structure here, you have vagus, which is A, D is recurrent laryngeal, and C is the phrenic, while B is ligamentum arteriosum. I think this picture This is what I'm asking and telling you about them. يلا كمل. Next.
Okay.
Yes, should be yes. Recurrent region is coming from the fetus.
Thank you, Dr. Baizid. Dr. Broaziz.
Good evening, everyone.
سوزان نسيت the next picture. Sorry, it's a previous picture for second one. مفيش بريك يا شباب. في ماتش ليفربول وليستر. ماشي يا حبيبي. انتوا عندكم في انجلترا ما بتطلعوش، ده بلد ما يعلم بالله ربنا. ماشي يا حكمت؟ انا عايز اتفرج على الماتش. خلاص. انتوا عايشين ازاي في البلد دي؟ اول ما جيت حكمت يقول لي هتعجبك. والله شوف انا بلعب في سلسفه لغايه دلوقتي، لدرجه ان انا الكورس نيكست هاند سون انا مش عايز اجي يا سوزان. يعني انا اي ام جلاند نوت
هتيجي يا دكتور صلاح.
مش عايز اجي والله
هتيجي إن
والله
شاء الله.
اكتئبت يا ستي.
سنينك.
اوكي اباوت
يا إدمان.
انا عايزك تجيب لي استراكشر اوف يا سوزان.
Which one?
وات از سي؟ هنا الازايجوس. سي this is the azygos. You agree?
Yes.
C is the azygos. Okay.
Yes.
Behind the azygos, you will find some veins, or above it, which veins? This vein going up for azygos. What is the name of this vein? This is
one.
intercostal. This is intercostal veins.
Yeah. Right superior intercostal vein.
Yes, and the posterior one, اللي وراه. There is one another behind it. This is a posterior intercostal vein. This question is also asked. Okay. انا عايز اقفل الصور دي لما تيجي، يعني this picture coming every exam. Every exam. Okay. يلا next.
Okay. An easy station. Which vertebrae are these, please?
These are lumbar vertebrae.
Would you identify the structures 1 to 6, please?
Okay. One is annular fibrosis. Two is a vertebral canal or spinal canal. Three is a pedicle. Four is lamina. Five is spinous process. Six is intervertebral articulation, superior vertebral articulation.
And what are the joints, please, between the two vertebrae?
Intervertebral disc joint.
Which kind of joint is it?
Can I pass it, please?
It's secondary cartilaginous joint. What motion does the lumbar spine have?
Flexion, extension, and lateral flexion.
And minimal axial rotation, very minimal.
Yes,
Would you
yes, for sure.
identify the anterior longitudinal, posterior longitudinal, ligamentum flavum, and mention the attachment of each of them, please?
For sure, anterior longitudinal ligament is 2, 3 is posterior longitudinal ligaments, and 1 is ligamentum flavum, and I would like to pass the attachment.
Okay, the anterior longitudinal ligament starts from the base of the skull till the sacrum, connects the anterior part of the or anterior surface of the vertebral body to the annulus fibrosus. The posterior longitudinal ligament, again from the base of the skull to the sacrum, but it connects the posterior surface of the vertebral body to the back of the annulus fibrosus. The ligamentum flavum starts from the skull to the pelvis, in front of and between the laminae and posterior, it protects the spinal cord and nerves, so it is the toughest and strongest one of them.
Okay.
How many lumbar vertebrae are there?
31.
We have 31 lumbar vertebrae.
Lumbar 5, sorry. Sorry, 5 lumbar vertebrae.
All right. What do you speak about the anatomy of the intervertebral disc, please?
Yes, the intervertebral disc is composed of 2 regions. The peripheral one is annular fibrosis, while the central one is nucleus pulposus with gelatinous it has a gelatinous property. They work as a shock absorber and pressure absorber between the two bodies of the vertebrae that are present.
What happens to the disc with aging?
As we age, these discs get degenerated because they get dehydrated. So dehydration and degeneration of these discs, it makes the annular fibrosis around the nucleus pulposus to be weakened and allows the nucleus pulposus, the central part of the intervertebral disc, to bulge backward posteriorly, and it may cause compression of the spinal cord or cauda equina
Or the
nerves.
nerve root coming out, the spinal cord. In posterior herniation on L4-5 disc, which nerve root is affected?
Yes, for sure. Regarding the L4 and L5, the nerves will emerge below the vertebrae. So in this case, it's L4 spinal nerve root.
Would you say it again, please?
L4, which nerve root? L4 nerve root will emerge.
It's L5. So would you show the area of sensory deficit for L5, please?
The L5 is dorsum of the foot.
Yes.
It's supplied by the L5.
What are the contents of the extradural space?
Okay, the extradural space contains fats, vertebral artery, veins, the spinal nerves.
Lymphatic network of internal vertebral venous plexus.
Venous plexus, yes, vein and arteries and nerve roots and lymph nodes, fats. And that's it for my side.
What is the significance of internal vertebral veins?
Okay, we have internal vertebral venous plexus. That's very important because it connects to the deep organs of the pelvis through a Barton plexus vein, Barton venous plexus. So any malignancy in deep pelvic organs from prostate, bladder, rectum, uterus, it will be easily metastasized to the vertebrae through these internal vertebral venous plexus.
Spinal cord ends at which level in adults and in children?
In adults, it ends at L1 to L2. In children, L3.
What is cauda equina syndrome? How does it happen?
The cauda equina syndrome is a medical emergency that happens when the spinal nerve gets compressed. It has lower limb nerve manifestations as numbing, tingling sensation. Also, it affects, it can cause erectile dysfunction, mitral or defecation problem for the patient.
Yes, it could be. If it is severe, it could be affect the sphincters. So it could be associated with incontinence, whether it is urinary or fecal. What is the space between the dura and ligamentum flavum? Name it, please.
The speed, according to my common sense, I don't know the exact answer, but I think the space between dura mat and ligamentum flavum, extradural space.
Yes, it is. What is the embryological origin of the vertebrae?
Can I pass the question, please?
It originates from the mesoderm. Okay, that's it for this station. Dr. Salah, do you would like to add any question for him?
No, he did great, and this station also not came for long time.
Okay, thank you, Dr. Brouaziz. You did amazing. Dr. Hiba, would you unmute your mic, please?
Yes.
No, now we are doing part. So would you identify the ascending aorta first?
The ascending, it's number 1, if I'm seeing clearly, or is it this is 3?
Of them, up or two, up or down?
The one at the top.
17.
Yes.
And here it's 9. What about the right ventricle?
17 is the pulmonary trunk.
Oh, sorry, you are correct.
Yes.
This one. And
Yes.
what about the right ventricle?
Right ventricle is 22.
Yes, here it's clear. And what about the right auricle?
5.
In which of them?
The one at the top.
And what about the one in the bottom?
The right auricle is 4.
Yes. And what about the conus arteriosus?
In the bottom, it's 7.
And pulmonary trunk?
It's 9 in the bottom, 17 at the top.
Brilliant. Would you mention the branches of the ascending aorta, please?
It's the right and left coronary arteries coming from the right and left coronary sinuses.
Would you mention the branches and the vertebral levels of the pulmonary trunk, please?
Pulmonary trunk gives the right and left main pulmonary arteries. They divided the level of the transthoracic plane, so at the T4, T5 level.
What are these structures, 1, 5, and 2?
So one is the anterior cusp of the tricuspid valve. 5 is the posterior cusp also of the tricuspid valve.
Are you sure? It's pointing to
No, that's the chorda tendineae, sorry. Yes,
What
it's pointing
about
to the
two?
chorda tendineae. 2 is the papillary muscle. That would be the anterior as well.
What are the functions of the chordae tendineae?
So they pull or stabilize the cusps of the AV valves, and they prevent them from prolapse during ventricular contraction.
How many cusps in the pulmonary valve?
3.
Yes, all valves have valves have 3 cusps, except the bicuspid or
The mitral. Yes.
What are the bony attachment of the diaphragm?
Okay, it's the I won't be clear, but there's the xiphoid process or the diphisternal joint. There is the lower 8 ribs, the inner surface of the lower 8 ribs or 6 ribs, I'm not sure. And then transverse processes of the thoracic vertebra as well.
Is it the thoracic or the upper lumbar? In the
Oh, sorry, yeah, the T12, L1, L2.
Yes. At which level does the IVC pierce the diaphragm?
T8.
Which part of the diaphragm does the IVC pierce?
The central tendon.
Which structure accompanying?
The right phrenic nerve.
Where to auscultate for the pulmonary and aortic valve?
The pulmonary, the left intercostal space peristernally. The aortic is the right second intercostal still also peristernally.
So both of them are second intercostal space peristernally. Aortic in the right and pulmonary in the left. Would you identify the structures 4, 5, and 6, please?
4 is the pulmonary trunk. 5 is the ascending aorta. 6 would be the superior vena cava.
Would you identify A, B, C, and D, please?
Okay, A is the brachiocephalic trunk.
Mm-hmm.
B is the left common carotid. C is the left subclavian, and D is the arch of the aorta.
Brilliant. Would you identify the structures numbered 1, 2, 8, and 9?
Okay, so 1 would be the right main bronchus on the left, on the right lung, yes.
Mm-hmm.
So
main bronchus. What about
yes,
2?
2 would be the right pulmonary artery or the pulmonary artery in general.
What about 8?
8 would be the pulmonary ligament.
And what about number 9?
9 would be the pulmonary veins.
Brilliant. What attached the lung to the diaphragm?
The lung to the diaphragm.
Yep.
The diaphragmatic pleura.
In form of the pulmonary ligament. So the origin of the pulmonary ligament is the diaphragmatic pleura.
Okay.
What structure pass in front and behind the hilum of the lung?
So in front of the hilum would be the phrenic nerves. Posterior to the hilum would be the sympathetic chain and also the vagus.
Yes, and the esophagus, definitely.
Yes.
What are structures pass through the central tendon of the diaphragm?
It would be the same of the inferior vena cava, the right phrenic nerve.
Yes. So the question here asked again, but in a different way.
Mhm.
Would you identify the structures A to E?
Okay. A is it pointing to the arch of the aorta? Both A and B are superior mediastinum, but I'm not sure.
So
So anterior part of the superior mediastinum and posterior part of the superior mediastinum.
I like it. Very intelligent answer. Continue, please.
C would be the anterior mediastinum, D would be middle mediastinum, and E would be posterior mediastinum.
Yes. So the middle mediastinum, we can call it the pericardium as well. So it is the
Mhm. Okay.
Would you identify the structures 1 to 14, please?
All right. Okay, that's a little bit. Okay, I can start with 14.
Start wherever you wish.
Okay. So 14 would be the common carotid artery.
Good.
Okay. So 11 would be the external carotid, while 13 is the internal carotid.
Brilliant.
And I can see 12 is a branch of the external carotid, so it's going to the thyroid gland. So I'm assuming this is the superior thyroid artery.
Good call. Continue.
For 6, that would be the nerve, hypoglossal, or
Yes, it is.
yes,
Mm-hmm.
it's nerve.
What about
So
the nerve number 7?
7, is it the vagus?
Yes, it is.
It's part of the carotid sheath.
Yes.
So now
And
5, is it a nerve? I can't see
yes,
clearly.
it is.
I'm not really
At this
sure.
level, we have the roots of the ansa cervicalis.
Cervical. Okay, yes.
What
Cervical
about number
plexus.
10? It is
10. This is the mark. No, it's not the mark. That's the facial vessels.
Yes, it is. It is a facial artery.
Mhm.
Okay, and what about number 4?
4 is the stylohyoid muscle.
Are you sure? We have a tendon in the middle, and then we have
No, that's a posterior belly band. Posterior belly of digastric.
exactly. And what about number 9 then?
9.
It is an artery.
That's the marginal mandibular of the facial
It is an artery.
artery.
Yeah.
That's the lingual artery.
Yeah. Coming to the lower jaw, so it's the inferior alveolar artery.
Okay.
And here up. An
It's
artery.
8, so still like that's a vessel, right?
Yes, it is.
It's branches of the maxillary artery, but
It is the maxillary, yes, exactly. What about number 3 here?
3 is this is the cervical plexus, so I believe it's the occipital.
Yes, it is occipital, lesser occipital nerve. What about number 2?
سوزان
2 would be the
سوزان صوتك واطي جدا.
What about the nerve number 2?
2 is the posterior auricular.
Yes, it's the greater auricular nerve. And what about number 1? The last.
1, middle meningeal artery, or is it a nerve? That's a nerve, right?
It is the main axillary artery, and here they
The
are
main.
branches. Yes. Well done. So, an easy question. What is this?
This is the
Structure.
submandibular gland.
Yes, it is. And would you identify the structures pointed to with arrows, please?
The arrow, that's the descending thoracic aorta.
This one, the big one.
Mhm.
What about those ones?
These are greater splanchnic branches.
They could be the branches of the sympathetic plexus.
Sympathetic chain.
And here it seems to be a vessel. What could be the vessel here?
A vessel, the posterior, that would be the azygos or the hemiazygos.
I believe it could be the hemiazygos.
Hemi,
We are
right?
looking at
On
the
the
left side
yes.
because the azygos runs in the right side.
Mhm.
And what about this structure here?
It's thoracic duct, or I can't see it clearly actually.
Actually, it's not clear even for me.
Yeah.
I'm not sure of it. It depends on the origin of the area. If they are pointing to this tuft, it's the pulmonary artery and its branches. But I'm not sure. But what is the structure here?
That's the sympathetic chain.
Yes, it is. Dr. Salah, do you have any comment on this picture?
Only the question asked also here about the branches of the sternum aortic aorta.
Yeah, we mentioned this question earlier.
Okay, I think is the only question about the sympathetic parasympathetic supply for the esophagus, lower part of the esophagus.
Sorry.
Hello?
Yes.
What I think this question asked in Cairo. Sympathetic and parasympathetic supply for the esophagus, lower part.
For the esophagus, the parasympathetic will be mainly by the posterior vagal trunk.
Okay.
The sympathetic will be branches from the sympathetic chain, forming the esophageal plexus.
Yes, I agree. Sympathetic chain and the parasympathetic, he's waiting the posterior vagal. He asked which vagus? Posterior vagal trunk. Posterior vagal trunk.
Yes.
Okay. I think also.
Could you handle this picture for me, please?
Okay. So I don't see all the letters, just 3 letters.
D and H.
Yes. So F would be again the azygos vein. G would be the esophagus. It's pointing to the muscle. H is going to be the vagal trunk, the posterior vagal trunk.
Yes, here we have the esophageal plexus of the vagal.
Yes.
Okay. If the body is tabbed at the epigastrium, which structures are at risk?
So we have the stomach, the pancreas, in terms of vessels, we have the celiac trunk.
The more structures are at risk with are the left loop of the liver, the stomach, and the diaphragm.
Yes.
Would you mention the boundaries of the caudate lobe and its blood supply, please?
I'm not sure, actually. I did not prepare for the abdomen part yet.
Yeah, but it unfortunately.
Okay, so it's the gallbladder, we can see. The gallbladder is the boundary, the porta hepatis, and the ligamentum teres, I can say.
Yeah, so anteriorly you have the margin of the liver, behind it is the hepatis, to the right is the fossa of the gallbladder, and to the left side of it is the umbilical vein. Well, would you mention one ligament connects the liver to the diaphragm, please?
It's the falciform ligament.
What does it compose of?
Falciform. It contains the ligamentum teres within it, I believe.
Yeah, this is the next question. What does it contain? But what does it compose of?
Compose of?
2 layers of peritoneum closely united together.
Okay.
It contains, as you mentioned, the round ligament and the paraumbilical veins. Would you speak about the venous drainage of the liver, please?
So it's mainly through so the portal vein will bring all the blood from the GI system to the liver through the portal circulation, and that will supply all the hepatic globules, and then it will be drained through the hepatic veins to the vena cava.
How many hepatic veins do we have?
We have 3, I believe.
Yes. So it occurs through the three hepatic veins to the inferior vena cava. Where does the hepatic artery pass?
The hepatic artery. It's part. It passes in the anterior margin of the epiploic foramen, the lesser omentum.
To which level could the lobe of the liver reach with enlarged horizontally?
I'm not sure, to be honest.
To the left midclavicular plane.
Okay.
At what level does the pulmonary trunk bifurcate?
It's T4, T5.
Yes. How to differentiate between right and left loops of the liver?
The right one is bigger.
Mhm.
It has the gallbladder. It has the caudate, the quadrate lobes.
Mhm.
It's like it's divided by the falciform ligament itself. So right to that would be the right lobe, left to that would be the left lobe.
Yeah. And the left lobe would be the one related to the biggest organ of that area of the GI, which is the stomach.
The stomach. Okay.
Okay, that's it. Dr. Salah, would you like to add any question for this very long, complicated? I believe you are so lucky, Hiba. We
I know.
to do with you today.
اسالي اسالي لا ما شاء الله ما شاء الله ربنا
You
يبارك كده
are ready to
ويخليك
go for your
ويوفقك
exam.
كملي على كده كملي على كده even I joined this Zoom meeting and I was so depressed by the way and my plan to keep with you 1 hour only and I will leave you with سوزان حاسس كنت منكم سوزان بقت كنت مكتئب but the way they start to be answered and to be active you are pushing me to be beside you تتعودوا ان انا اكمل معاكم بصراحه يعني even I'm trusting all the team يعني سوزان she can do big course alone يعني if someone wants competition against Salah will do course alone I will advise you go for Suzanne go for Maria go for Murad if they will do course alone I trusted these people يعني I know and by the way I told very important thing in all courses you know why no competition against us even they will take our materials because they can bring one like Suzanne they can bring one like Maria if he can do that لو دفع لماريا وسوزان فلوس كتيره وخدهم هقول لك انت هتعديني يلا يا سوزان دور عليه
بالظبط احنا هننزل المزاد.
دور عليه ماشي no, no, but they are doing amazing they are doing great by the way يعني most of them they are doing great كويس الشباب كملوا على كده بتطمنوني بصراحه
Dr.
بتفرحوني
Abdullah, will you unmute your mic, please?
Yeah. Can you hear me?
Yes, it's clear now. Would you identify the pathology in the MRI image, please?
Meningioma.
I didn't ask you about the date.
Okay. You can see a hyperdense mass in the I don't know. I'm not too sure actually. Hyperdense mass. That's what I have.
Yeah, pretend that you are seeing it for the first time and try to describe it. Yes, you have a hyperdense mass here. What are the three structures will this tumor affect once it grows?
It can affect the superior sagittal sinus. It can affect the cerebral hemisphere, and it can also affect the I think maybe the middle meningeal artery.
The motor area in the hemisphere.
Motor.
The clinical picture of this patient. Have a patient with this tumor this side.
Yes, they will have contralateral lower limb monoparesis.
Yes. What area of the brain could be affected?
The motor area 4.
Yes. Major or main motor area, which is number 4. Which layer of the meninges is meningioma attached to?
The dura mater.
Good. Would you identify the following structures in this MRI? Start with the pituitary gland, please.
Okay. The pituitary gland. It would be where number 17.
Yes, this is a small structure. What about the fourth ventricle?
Actually, I don't know about the fourth ventricle. No, it's
Here,
15.
just in front of the cerebellum.
Yes, 15. Fourth
What about the
ventricle.
corpus callosum?
Corpus callosum. It would is it number 6?
It's 2, 6, and 18.
Yeah.
This part.
The splenium and
The
the
cerebellum?
it's the cerebellum is number 9.
Yes, definitely. And what about the cerebellar tonsil?
Number 8.
And what about the cisterna magna?
Number 13
And interpeninsular cister?
is the green arrow.
Yes, yeah. Brilliant. Okay, would you demonstrate in the skull the course taken by the sinus system starting from the superior sagittal sinus, naming all the sinuses till forming the internal jugular vein?
So the superior sagittal sinus will go to the confluence of the veins, and on the other hand, the cerebral veins will go to the I think it's the straight vein, and will also go to the confluence of veins.
Mhm.
From there, the confluence of veins, they will go to the transverse veins, which will go to the sigmoid veins, and then that will
How
go.
does the transverse sinus form the sigmoid sinus? What
Uh,
does it unite?
how does it transfer?
Yeah.
I'm not sure.
The transverse sinus joins the superior petrosal to form the sigmoid.
Okay.
Then what happens?
And then the sigmoid, it will go to the internal jugular vein.
It receives the inferior petrosal to form the internal jugular.
Okay.
The transverse receive the superior petrosal forming the sigmoid, and the sigmoid receive the inferior petrosal forming the internal jugular. And the confluence of sinuses is formed by 3 sinuses, which are the superior sagittal, as you mentioned, the straight sinus, and the occipital sinus.
Okay.
What is the major vein draining the brain parenchyma?
The great cerebral vein of Galen.
Would you show the position of the cavernous sinus in a skull?
I don't know. How do I show it here?
Describe where does it lie?
I think it lies in the middle fossa.
Yes, in both sides at the greater wing of the sphenoid, just lateral to the area of the diaphragm cell, lateral to it in both sides. What blood is received in the dural venous sinus?
In the dural venous sinus, you get blood from the superior ophthalmic vein and the facial vein, and I also think the inferior ophthalmic vein as well. And also you get blood from the pterion plexus.
So it received 2 parts or 2 types of blood from the deep system and the superficial system, as you mentioned now. What structure signed for it or pointed for it with the red arrow?
The red arrow, not the hyoid, or
This black area. The hyoid is here.
yes, the esophagus maybe. I'm not sure. The pharynx. I'm not sure. The trachea.
Epiglottis.
Epiglottis. Okay.
Show the parieto-occipital sinus. I believe we showed it clearly in the one of the previous stations. Which neurological area in the precentral gyrus?
That is the motor.
Yes. Which part of the body represented in the medial side of the motor area?
Lower limb.
What is the difference between upper motor and lower motor neuron facial palsy, and what causes this difference?
In upper motor neuron facial palsy, it will affect only the contralateral lower side, while lower motor neuron will affect the whole or everything, both up and is it ipsilateral side? Yeah. And
Yeah,
why?
it is. But why? What causes this difference?
Because for upper motor neuron, there is from the contralateral side of the brain, it can receive innervation from that side, and
Because the upper part of the face receive dual nerve supply. So if
dual
it
nerve
is
supply.
upper motor, so the distal innervation will be intact and from the other side. But if it is distal or lower motor neuron, so the whole side will be affected.
Mhm.
Other than circle of Willis, what is the major source of blood supply to the brain tissue?
The middle cerebral artery.
Yes, because it doesn't participate in the circle of Willis. Would you describe the course of the vertebral artery starting from the arch of the atlas? In
Uh,
this question, sometimes they give you the cervical vertebra to point in it and show the pathway. So would you describe it, please?
So it moves upwards, forwards, and medially until it comes to the front of the medulla.
Where does it pass exactly?
Sorry.
Where does it pass? In which area?
Is it the transverse foramina, maybe?
Yes, the foramen transversarium.
Okay.
Mm-hmm.
It joins at the base of the pons to form the basilar artery.
Yes, well done. Okay, that's it. Dr. Salah, would you like to add any question for him?
You can expect that Suzanne, one orthopedic like me can answer this station without preparing it. This was my station, by the way. I like his way. It was a very important station, and I think Dr. Suzanne added many things. And like I told in the beginning, the feedback came for me also from Murad that our candidates are stuck to the questions in our book only. Extend your knowledge. You don't know what is going exactly in exam. So I think discussion of this station is amazing. This station, by the way, not came since a long time, but uh, it's very important and it's still in the kitchen of the Royal College to come, especially in New Year in 2024, 2025. تمام?
Okay, Dr. Tariq, we are finishing now. The last two stations. Dr. Tariq, are you with me?
Yes. Oh,
Again, I can't hear you, Dr. Tariq.
yes. Now can you hear me?
No, it's so far.
Hello. Now can you hear me?
I can't really. It's very low.
Sorry, I will adjust. Hello, Dr. Suzanne. Now can you hear me?
It's a bit better, but I don't believe it's good enough for the recording.
Still far?
It's worse now. I can't hear you. There is an
No.
echo.
Oh, I'm sorry.
So I will unmute Dr. Bayezid. Meanwhile, you can adjust your connection. Hello, Dr. Bayezid.
Hello.
Hello.
Yes, can you hear me?
Yes, it's clear now. Would you mention the middle cranial fossa boundaries, please?
Yes, anteriorly it is bounded by the lesser winged sphenoid, the tuberculum celli, also the anterior cleaner process. Then posteriorly it is bounded by the dorsum celli and the petrous part of the temporal bone. And the laterally it is bounded by the temporal bone, the squamous part.
In extradural hemorrhage, which vessel is affected?
The middle meningeal artery.
Well, and what about the subdural hemorrhage?
the cerebral veins and the bridging veins.
Yes. How does intracranial pressure affect the oculomotor? This is a repeated question. What are the high intracranial pressure consequences?
There will be headache, vomiting, the focal neurological deficits, also the Cushing reflex,
Mhm.
papilledema.
Mhm. What
Also,
happens before all of that?
um,
Impaired mental status
yeah, altered mental
is
status.
the first thing happens. Do both oculomotor nerves being damaged at the same time or one after another?
No, one after another.
Yeah, usually the affected side will be affected first, and if it progressed to increase intracranial pressure globally, it affects the other side as well.
Yes.
What layers are encountered after bone and before reaching the brain? What is the layer immediately after removing the bone?
Immediately after removing the bone, it will be the dura mater
And
and
what is the layer before reaching the brain?
the pia mater.
Yes. Where is the CCSF located? This is a repeated question. If a lesion in the central gyrus, this is a repeated question. From where does the oculomotor nerve originate?
The midbrain.
How does it come out of the skull?
The superior orbital fissure.
What is the first sign of compression due to high intracranial pressure?
The dilated pupil.
Yes. So if they ask about the first sign of compression of the oculomotor, it's mydriasis with the dilated pupil. And if they ask about the first sign of increased intracranial pressure, it will be impaired mental status. What is
Yes.
the muscle affected when ptosis happens?
The
We mentioned it.
yes.
What is the structure related to the cella turcica?
The pituitary gland.
Yes. Or the pituitary stalk, as they like to call it. Okay, well then, I believe most of the questions were repeated, so we are finishing now. The last station will be for who is the one?
Please شباب يعني please regarding of some questions maybe not discussed today and discussed in previous mock, please read everything we shared in notes group. Please read everything in notes group. If any question not discussed now, please read it. Maybe we missed one question or two questions in any station. Please, the proper way in studying, read the notes group, every word, every word. Okay?
Dr. Razi, are you with me?
Yes, Dr. Susan.
Okay, so the first question is repeated, so we bypassed it. What do the vertebral artery and basilar artery supply in the brain?
Okay, so the basilar arterial system supplies the thalamus, occipital
I can't
cortex,
hear you,
and
sorry.
pons, and also the spinal cord.
I can't hear you. Would you start the
So the
answer from the beginning?
vertebro-basilar arterial. Dr. Susan, can you hear me now?
Now it's better, yeah.
Yes, sorry, it was some network problem. So the vertebro-basilar arterial system supplies the thalamus, occipital cortex, pons, medulla, midbrain, and also the spinal cord through anterior and posterior spinal arteries.
Brilliant. What are the clinical features of middle cerebral artery occlusion?
So if the middle cerebral artery is occluded, then there will be contralateral lower limb paralysis. There will be contralateral paralysis of the lower half of the face and aphasia if in the dominant hemisphere.
Yeah. Exactly. Would you identify in the angio of the internal carotid artery the structures number 3, 4, 7, 9, and 2?
Okay, so the structure number 7 is ophthalmic artery, and the structure number 2 is posterior temporal arteries, posterior parietal arteries, and structure number 3 is a middle cerebral artery, and structure number 4 is, sorry, I can't, and 9 is anterior cerebral artery. But what is number 4? I can't recall it, Dr. Susan.
Well, 7 is ophthalmic, as you mentioned. Number 9 is the anterior cerebral. Number 2 is the posterior temporal, middle cerebral. Number 3 and number 4 are the posterior cerebral artery.
Especially.
What is the pathology in the cerebral angiogram?
Okay, I can see that there is an aneurysm in the angiogram.
What happens if it ruptures?
Oh, okay. So if this aneurysm ruptures, then there will be subarachnoid hemorrhage.
What is the first branch of the internal carotid artery after entering the skull?
Okay, so that one will be the ophthalmic artery.
Would you name the branches of the middle cerebral artery?
Okay, so there are lenticulostriate arteries, there are orbitofrontal branches, there are parietal branches, there are posterior parietal branches, and temporal branches. So among parietal, there are anterior, middle, anterior, posterior, and angular. And among the parieto orbitofrontal, there are precentral, central, and postcentral branches.
Yes, and don't forget the cortical branches, please.
Cortical branches.
How
Yes.
does the internal carotid artery enter the skull?
So the internal carotid artery enters the skull through the carotid canal, passing over the foramen lacerum.
What is the blood supply of the brain other than circulatory?
Middle cerebral artery.
Yes, the cerebral. I have finished, Dr. Salah. Do you would like to add any question for this station, Dr. Razi?
No, I remember the feedback since last MOOC, Suzanne. I shared all the feedback came for us. I think you went for the group, part
Yes.
B channel. You find anything updated in our since last September?
Actually, maybe 1 or 2 pictures only and no extra questions. That's what I do believe.
So the feedback came for me from all centers since last MOOC was in September. No more new questions. This is not the question to be asked. Are the answer already written somewhere? Not written. Not written. Help me in keeping the secrets. Write your notes by your own self. I think this is the best way. This is the best way. Still, many of you, people going for Malaysia exam or Hyderabad in January, they have no time for that. The old MOOC is enough if they listen for the old MOOC. But people going for UK February exam or Cairo or Mumbai in March or in April, they have time. They have time. يا شباب, after tomorrow, inshallah, I will be with you with Dr. Maria, upper limb, lower limb, and abdomen. Thank you, Dr. Suzanne. شكرا. This will be in the website. يا ابني ما هو طبعا هيبقى الويب سايت. For sure, anything we are doing live will be in the website. We have more than 1,000, around 2,000 candidates with us. We have around 2,000 candidates. So only joined now 100. What about the remaining? مش الاسئله يا شباب، خلاص احنا بقينا 10 دلوقتي، بقينا 10. اوكي، يلا نشوفكم على خير ان شاء الله. افطر tomorrow. مع السلامه.